Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. My two daughters love sledding. There's a hill about a mile down from where we live where all the kids in the neighborhood gather to go sledding. It's not a big hill, but it slopes in a way that the first part has a very gradual descent, which is where my girls first gathered the courage to get on their sled on their own. And then at the other end of the hill, it's a little bit steeper. There's a nice bump in the middle so that if you gather enough momentum, it can even get you some decent airtime. Unfortunately, this past winter was lousy for sledding. Boston received less than a foot of snow instead of the usual 3 feet, and temperatures were 6 degrees Fahrenheit above normal, which meant that any snow that we did receive quickly melted. It was one of the warmest winters on record. The thing is, climate change is not just affecting my ability to go sledding with my kids, but it may actually have broader implications for our health as well. How people with rheumatic diseases may be affected by climate change is a topic that I never even considered until recently, when I read a wonderful call to action published by Dr. Paul Dellaripa and colleagues. So in today's episode, I invited Dr. Dellaripa to discuss why patients and providers should be concerned about climate change and how increases in heat, pollution, and allergens may negatively impact people with rheumatic diseases. We discuss how climate change could contribute to the development of autoimmunity in people who were otherwise previously healthy, and how these factors may also cause exacerbations of a patient's underlying rheumatic disease. We discuss the drivers of climate change, including the role that the healthcare system has in contributing to waste and the production of greenhouse gases. But most importantly, we discuss what we can do about it, both as individuals at home, as professionals in our clinical practices, and as educators to our patients and medical trainees. Dr. Dellaripa is a member of the Division of Rheumatology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. He founded the Interstitial Lung Disease Clinic at the Brigham and has led a multidisciplinary team of clinicians and researchers to study and treat ILD. He has fellowships in rheumatology and critical care, and so he brings a unique perspective to the topic of climate change. I really hope you enjoy these important discussions. Paul, welcome to the show.
Thank you, John, for inviting me.
So we're going to talk about climate change, and certainly that's a topic that's on everybody's mind. But why should I, as a rheumatologist, care about climate change within my professional practice?
Right. I think that's a good question, John. I think that up to this point, from the rheumatologic perspective, there hasn't been a lot of discussion or a lot of study on what the role of the effects of climate can have on our patients. But we do know that the effects of climate, whatever they may be, can have effects on any group of patients with chronic diseases, cardiac diseases, pulmonary diseases, allergies, psychiatric diseases. And since our patients, many of them have systemic diseases, but it seems to make sense that in one way or another, those effects of climate, whether it's heat or smoke, pollution, infections that might change dynamically with climate change, could theoretically affect our patients as well. And just because we have not looked at it in any detail doesn't mean that it's not either happening or going to happen. And I think we need to prepare ourselves in that regard.
Yeah. So talk to me a little bit more. You mentioned how climate change may affect people with cardiac disease and pulmonary disease. Can you tell me a little bit more about some of the evidence about how climate change is already affecting people with other types of disorders?
Sure. Some of the specialties have already been sort of working on this for a number of years. As you know, for example, wildfires, which are prominent out west and in Canada, have really shown that patients with pulmonary disorders, asthma, and allergies have had significant exacerbations of their diseases, leading to an increase in hospitalization. The cardiologists have been looking at exacerbations due to wildfire exposure and pollution exposure associated with that, both in terms of sudden death and complications related to congestive heart failure. And the nephrologists have been looking at this as well, looking at populations that have been exposed to heat and found risk of new renal disease and exacerbation of underlying renal disease as well in selected populations, agricultural communities, and so forth. So those are just a few of the examples where data has already begun to be accumulated, looking at some of the effects that can be associated with climate change in this country and other parts of the world as well.
Wow. And certainly for most of the rheumatic diseases that we care for, we don't really understand what brings them on. There may be some genetic predisposition, but we always talk about that the environment may affect the development of autoimmunity. So in what ways do you think the environment and climate change in specific can affect people with rheumatic diseases?
Well, I think that some of this came out of some data not related at all to climate. And there was a paper, you may recall, looking at the after effects of 9/11 dust and exposures in the World Trade Center, and the fact that they found that there was a higher incidence of rheumatic disease that appeared to be associated with that exposure. And that's a difficult study to do. But I think the point of that was that they were looking to see if this sort of singular event played a role in the development of disease that was more frequent post-exposure compared to a pre-exposure expectation in a similar population. And similarly, what we think is that the question really is do these types of exposures that might be associated with climate, whether it's heat or wildfire or other effects, cause changes in the immune system, whether it's by inhalational effect or whether there are effects that are epigenetic in relation to diseases, development of diseases, or exacerbation of diseases. So there is some data, but the data has mostly looked at the effects of sort of garden variety pollution that people might be exposed to, and not the effects due specifically to exposure to climate events. So that's where we don't know enough, which is that we haven't taken the opportunity up till now to study what happens to populations of patients who are exposed to wildfire and what happens to their immune systems or what happens to their rheumatic disease if they're exposed. So that's where the gap in our knowledge is at this point.
Yeah. And as you were talking, I was thinking, well, inhalation, how can that affect rheumatic diseases? But then I remembered rheumatoid arthritis, right? One of the biggest risk factors is smoking. So I wonder if inhalant pollution, things like that, might cause the same harm that smoking does, either to develop a rheumatic disease or to worsen an existing rheumatic disease.
Yeah, I think the whole inhalational hypothesis associated with rheumatoid arthritis and the development of citrullination that can occur with that inhalational process is something that is very interesting with regard to the effects of smoke and PM exposure or particulate matter exposure, to be more specific. I think one of the things that this brings to mind is that it's not ideal that this is happening, but one of the co-benefits of studying this phenomena is that it may offer us insight into mechanisms of disease with our diseases that we don't understand right now, because there's a natural environmental laboratory that's actually occurring due to these terrible events. And so that opportunity exists for us to gain insight into diseases in ways that we can't do right now. So I think that is another way to look at this, which is to fill gaps in our knowledge in terms of the mechanisms of diseases that we deal with.
Yeah, I think you mentioned, the World Trade Center, and I think I remember hearing that incidences of sarcoid among that group exposed to the 9/11 attack was also increased. And again, sarcoid seems like it's another one of these disorders that may have a large environmental component in possibly influencing its development.
Yes. And sarcoid being a disease that can present in a myriad of ways. And the sarcoid lesion, if you will, might be a sort of final common factor related to many types of environmental exposures that we don't simply understand very well. So yeah, sarcoid is one of them. But RA, yes. Lupus, how about in scleroderma? I think that these are all other possibilities where understanding how some of these types of exposures could potentially play a role in the pathogenesis of disease.
Yeah. Paul, how did you get interested in climate change? I mean, we've known about climate change for a while, but I think you're the first person to sort of start writing about it within the rheumatology space. What is it about you or your background that made you particularly interested in this?
Well, I think back in the 2010, 15 range, I started to see some patients who were coming in. So, for example, one of my rheumatic disease patients had been in Australia and had been exposed to a wildfire there and had to actually get out because her underlying asthma had become so bad that she traveled back to the United States. But her asthma was out of control, so I had to admit her onto my hospital service at the time.
This is back when you were a pulmonologist.
No. I mean, I still do a fair amount of hospital medicine as well. So I happened to be ward attending when she actually was admitted to the hospital. And then I've seen other patients in clinic who've presented with ILD in the ILD clinic that seemed to follow their exposure to a wildfire in California a couple of times. And so I couldn't create causation between their exposure and the development of their interstitial lung disease, but it did raise the question as to whether that had somehow played a role in the development of their disease. So I started to see these 2 or 3 or 4 patients, and I began to wonder, I'm like, if you're a patient with rheumatic disease and you're caught in a haze of wildfire smoke and you already have ILD, A, that can't be good for you. So you could be at an increased risk for hospitalization and flare. And then B, if you inhale this stuff and you're a normally healthy person, but you have some sort of genetic predisposition, could you be at risk for the development of disease? There just wasn't really any data or effort put forth at that time to begin to look at whether this was happening and how to study it. And, I proposed 2 years ago to the ACR to begin to tackle this concept. And to their credit, they put us on the agenda for the ACR meeting. We have a working study group going on. And then the ACR, if I might move on to what the ACR is doing, the ACR, has commissioned us to write a white paper to put this issue in perspective to inform the rheumatologic community about where we are and directions we can move forward in.
Well, that's fantastic. Are other groups of physicians doing similar work in trying to study how climate change affects patients with their disorders?
Yes. And so there are groups certainly in the pulmonary community, the allergy community, the cardiovascular community, and the renal community who have active groups who work on this as well. So we're a little behind them. So we hope to begin to move forward in a way to explore this in more detail.
Great. And I think it was very wise of you to bring that to the ACR. And I'm glad that the ACR is taking it seriously. So when is that white paper expected to come out?
Well, John, we are working on it as we speak. And so we've been diligently moving forward and hope to have something, I don't know, in print, but we hope to have a working paper available before the end of the year, certainly.
Great. Really looking forward to reading that and certainly learning more about climate change within patients with rheumatic diseases, because I imagine, as you mentioned, there's a lot of questions that we need answers to if we're going to be able to care for people, over the next decade, over the next several decades, with climate change looming in the background or close to being here. I wanted to ask you a little bit about your background, because you also have a unique background. I believe you was initially a pulmonary and critical care physician.
Critical care. Then a sort of transition more into a rheumatology practice. Can you speak more about that background and why you made those choices? Well, so I started out, I did my rheumatology fellowship first. And then I actually took some time off, actually worked in an ICU for a year, and then went back and did my critical care fellowship, and then worked for about 11 years doing both my ICU rotations, critical care rotations, and had my rheumatology practice as well. So it was sort of a nice mix of inpatient and outpatient practice. And I think that as time went on, these ILD patients who had rheumatic disease, the pulmonologist would just say, Paul, we don't know what to do with them. You take care of them. And so I started to build up a practice that was focusing on autoimmune interstitial lung disease. And then when I moved from the Leahy Clinic to the Brigham, we started our first multidisciplinary ILD clinic center for patients with all kinds of interstitial lung disease. So IPF, RA-ILD, scleroderma, myositis, drug-induced, whatever the cause was. We work together, pulmonologists, rheumatologists side by side. We have an active registry, active research, clinical trials. It's just great. And I think that it's the real way to put everyone's expertise together for these complicated patients. And we've been at it now at the Brigham since 2007. It's a very active program. I'm proud that it's moved in the direction as it has it over the years.
That's great. And is there any plans to study climate change within some of those patients?
Yeah, I think that's a good question. I think that we have begun, I think that your point is well taken, which is how do you incorporate exposures in patients with rheumatic disease and ILD? And to this point, we have not done that. I think that what we might be doing or should do is to look at patients' vulnerability based on their exposure in the past, their proximity to particulate matter exposure, whether where they live or their occupations, or heat exposures, which could exacerbate underlying systemic disease. That we would need to tackle, I think, in a different way. We've begun to do some of that in the rheumatologic clinic with Candace Feldman and one of her colleagues, Leah Santa Croce, where we've begun to look at heat maps in the Boston area and to correlate vulnerability of our rheumatic disease patients with regard to recurrent hospitalizations. So that's data that we've begun to cull from our database of MGB patients who we take care of. So that's one approach that we've begun to take.
That's great. I wonder if you've thought about how climate change may affect groups that have been traditionally marginalized, such as those from racial and ethnic minorities.
Yes, and our work on the heat exposure area did show that there was a significant overlap between those areas with the highest level of heat and social vulnerability. So urban areas where people with sort of more higher risk or more socially marginalized certainly seem to be the populations that are going to bear the brunt of these climate effects. So if you live in a city, you have concrete everywhere, you have no shade, maybe you don't have air conditioning because you can't afford it, and you have a systemic disease, whether it's rheumatoid arthritis or you have renal lupus or congestive heart failure, is that the patient who's going to be more at risk for effects of heat? And the answer is yeah, that patient is at risk. And all over the world, the effects of climate will affect those who are more marginalized in terms of their resources, whether it's due to economic resources or racial disparities. Those people, I think, will bear the brunt of this effect going forward.
That's very upsetting to hear. And it seems like these marginalized communities just get the short end of the stick in so many ways. I wonder if you've thought about the role that healthcare has on climate change. Are we partly to blame? Are we doing stuff that's making the environment and our patients worse?
Right. Good question. So healthcare in general in the United States takes about 8% of all greenhouse gas emissions. Some people say it's closer to 10%. It's kind of death by a thousand cuts. It's not like just one thing, like heating the buildings or, the research lab or whatever. It's the operations of a healthcare facility, as you are well aware, is an expensive and expansive process. But we have the highest level of greenhouse gas emissions of any healthcare system in the world. And it probably doesn't surprise you. So the issues really are is can we begin to look at what the inventory of our greenhouse gas expenditure is and then work on ways to limit that by limiting waste? In the broadest sense, can we do our work with less, and can we do it more efficiently, use less energy, which requires fossil fuels, or obtain the energy that we use to power our healthcare practice with renewable energy as much as possible? So the goal in all sustainability systems is to utilize renewable energy as much as possible, to electrify your systems as much as possible, to limit waste as much as possible, because recycling is very, very hard, as you know. Recycling, if you take 100 pounds of stuff that could be recycled from anywhere, only a fraction of that is actually physically recycled, maybe 5 or 8%. Most stuff ends up in a landfill. And so we need to find ways to reuse and to limit use as opposed to relying on recycling, because recycling is hard to do.
And it's energetically expensive, right?
Yes, exactly. Yeah. So the healthcare system, our goal is not to emit greenhouse gases. Our goal is to take care of patients. We just need to find ways to do it more efficiently. And you and I know that there's always waste in healthcare. You don't have to go far to find it. And yet most institutions have not undertaken an inventory where they go through every single part of their practice, their research facilities, and look for ways to limit waste. And to the co-benefit of limiting waste for any institution or healthcare institution is you limit cost. And so with everything that you can do in fighting climate change, there can be a co-benefit. And for healthcare, one of those co-benefits can be limiting costs because you waste less resources.
Yeah. I mean, I'm just thinking in terms of my clinic and seeing patients, there's a lot of physical papers that get shuffled around in the process of seeing a patient, whether it's intake forms or lab slips or things like that. Multiply that by all the patients that, all the doctors are seeing every day is literally probably tons of paper. And that's just one aspect of the medical system that may be able to be reduced. We've talked a lot about the problem that climate change is real and it has the potential to affect our patients, both in terms of maybe increasing the risk of developing autoimmunity, or in those that have established autoimmunity, making it worse. So where do we begin? You mentioned, okay, cutting back on waste, but what should I do? What can you do as a person, as a physician? Where should we begin?
Well, look, I think that there's different ways to tackle this. And part of the way to deal with this is to look at climate and to look at your life activity at work, at home, how you recreate through the lens of its effect on climate and the environment. So when you come to work, what are the things you can do to limit waste? When you come to work, how can you begin to adapt your practice to maximize the ability to mitigate the effects of climate? And that might be a patient that you recognize is at risk for exposure to climate. Let's say a heat wave is coming next week. You got a patient coming in. they have renal disease, they're on a drug that can be affected by dehydration. You need to have the ability to react and to be prepared educationally to talk to that patient and educate that patient to help them be prepared. And so your knowledge of integrating the effects of climate into your practice is something you're going to need to be able to do. So that's at a practical one-to-one level. The second thing we're going to need to do as a group is we're going to need to translate this information to those populations that are at highest risk in our community. And how are we going to do that? Are you going to do it individually? Is Epic going to do it for you? Doubtful. So what we need to do is we need to develop better relationships with communities, the local level, ground level, so that we can transmit this information to them so they can help educate their own communities. It's not going to work one by one piecemeal to disseminate this information in a way that's going to help individuals. It's having tools and knowledge to understand which groups of patients in which locations, which zip codes are vulnerable, and creating conduits of communication with those groups of people through community activists and community agencies, which can help move that information in a way that educates people locally and empowers them, I think, to educate them locally. And I think that's what we don't do well enough of, in medicine. We wait for them to come to us. And the question is can we use this information that we're going to gain and give it to them and help them transfer it and translate it to their populations locally? I think we can do that. So that's one idea. The second thing is how do we sort of adapt our professional lives? Do we change the way we live a little bit? Should we be more conscientious of how we use energy? I think physicians need to set a good example. And we're trusted resources. Remember, people still listen to what doctors say for the most part. And I think that we have the ability to translate this information, and patients, legislators, community groups, hospital administrators can listen to us if we can put together a cogent argument and plan about how we need to tackle this issue. So being trusted sources gives us an opportunity to influence how this moves forward. We're not powerless, is what I'm trying to say.
Yeah, and I love the idea about education. And I imagine that needs to start as physicians from medical school, right? Like when I went to medical school, we never addressed climate change. And as we go forward, I love the idea about educating patients and having sort of communities educate their members to try to address climate change. Can you provide us with some examples about what you've done, either locally, in your city or what you're doing at the Brigham in relation to climate change, just to give people examples about what they can do?
So, I think that the easiest sort of low-hanging fruit is the educational part of this. We have established an educational framework here at the Brigham for the internal medicine residency program. We've had a number of very active members of the internal medicine residency that we've worked with to create their own climate and health committee within the medical residency, and established a curriculum that's embedded within the internal medicine residency as well. So that has been a really great thing, which is looking to educate not only attending physicians, but also the residents have begun to fan out to all the different specialties, outpatient clinic conferences, didactic conferences, inpatient conferences, morbidity conferences, all of these things where elements of climate can be integrated into the curriculum. There's been a cadre of attendings who've worked with the medical residents to accomplish this. And this is also being done at the medical school as well. So the medical school has its own curriculum that Gaurav Basu, who's a physician internist at Cambridge Alliance, who's been working on this, and we've been working with him. So really, the whole climate curriculum is being integrated in many, many medical schools now. And that's the right place for this to start, in my mind. So the education piece of this is extremely important within our educational framework.
Yeah, I imagine that it's going to be the the medical students and residents that are going to be teaching us about these topics going forward.
Absolutely.
Sort of speaking practically, what are some of the ways that we can think about lowering our carbon footprint, either both professionally or personally? Like you mentioned, going to work, maybe riding a bike instead of driving a car. What other things do you think are sort of low-hanging fruit and fairly easy for people to adapt over time?
Yeah. So, I think that all of us who are in the medical profession, there are tough trade-offs to make about how you limit the energy that you use. Certainly, many of us drive our vehicles and go to work that way. Yes, if you can walk, it's better. Yes, if you can take public transportation, yes, it's better. Yes, if you can e-bike, it's better. But many people still drive, and people should make a commitment to the extent that they can to utilize electric vehicles going forward. That's going to be a huge push in our population. And EV vehicles emit maybe 40% greenhouse gas emissions compared to a typical internal combustion vehicle. So, you could have a huge savings, all these people driving around. And so that's, I think, an important first step. I think that at work, people can join their committees or groups within their own hospitals to limit waste. We have something called the Climate Action Council here at the Brigham, which I'm a member of. And we look for ways for each department, division, all people, nurses, anesthesiologists, everyone can play a role in looking in their own workspace and seeing how they could improve the emissions associated with the work they do and how they could make it better. So I think that each hospital, each division, each individual can play a role in these groups that exist in many, many hospitals now. So sustainability in most hospitals now occurs. There's these sustainability groups in many, many health institutions, and anyone can join. Anyone can be a part of it and play a role in that. So those are a couple other things that people can do.
Great. And how about recommendations for patients, both in terms of what they can do and things that maybe they should be speaking with their rheumatologists about?
Yeah, so I think that one of the things you want to be careful about when you talk to patients is you don't want to hit them over the head with climate. They come to see you for their RA or their JIA or their lupus, and then you don't want to preach to people about how they need to walk more to save the planet. That may not work. But the way to do it is to emphasize what we call co-benefits towards things that can improve or limit greenhouse gas emissions, but also improve health. So when you say to patients, you need to walk more. If you have a grocery store near where you live, can you sometimes walk instead of taking your car? If you eat less red meat or you have a better diet, plant-based diet, you'll have a healthier diet, which will be better for you, but it'll also save on emissions. And you don't even talk about the emissions. You emphasize the health benefits, and you get the same co-benefit between the emissions and the health benefit based on the action you're trying to promote. So more active ambulation, better diets, all these types of things that we've been always talking about can have the co-benefit for climate as well.
I love that idea of co-benefit. I remember I was sort of discussing with my wife, we've both been trying to reduce our carbon emissions. And we're talking about buying something, whether it has a paper bag or a plastic bag. I remember reading a study about the impact that just eating less beef has on the environment, and that can be 100 times the effect of paper versus plastic. So that's one of the things that we've been trying to reduce, is just eating less red meat and hoping with some other stuff that has some benefits in the environment. So I think also thinking about the biggest bang for the buck, right? That spending time, paper versus plastic may not be such a useful spend of your time. Whereas if you could go mainly in a plant-based diet, that's going to have a huge effects on the environment. And certainly, as you mentioned, on your own health as well.
Exactly.
Great. When you bring these topics up, do you ever get people that, may not buy into this idea of human-made climate change, or people that aren't interested in discussing this or don't see it as a problem. I wonder if you have ways of how you've been able to address that in the past.
So yeah, I think, like I said before, it's rare that I actually use the word climate in my clinical practice. I use the word pollution a lot. I think pollution is something everyone can relate to. No one likes pollution. If you have interstitial lung disease and you're exposed to more pollution, whether it's where you work or what you might be exposed to in the environment, those are things that most patients can simply relate to, and you don't even have to go into the concept of climate. Similarly, when you're talking about heat exposure, you can say to patients that these heat waves that are occurring can have an effect on your health. And that's what you need to be worried about, and you need to protect yourself. You don't have air conditioning. You need to go somewhere where there's air conditioning. You need to make sure that you're hydrated. So we tend to keep it rather practical. I tend not to get into wording that could be politically construed and then turn people off. Because there are some people who, A, don't want to hear about it because they're in denial. There are a small number of people who are still in denial about this. That number has shrunk, generally speaking. They're still out there, but not as much as before. But I just think a lot of people are daunted by the whole thing, and we can offer them practical approaches to dealing with this that can help them deal with it in a way that doesn't create too much anxiety or make them feel like they're powerless. Doomerism is not part of the landscape or lexicon here. So I like to say doomerism, not okay. The old okay boomer, we go doomer, not okay. Because we just think that our world, while is dealing with this, we've undergone already a revolution in the way we can deliver energy by renewable energy, which is rapidly caught up to cost-wise fossil fuel energy. It's been amazing if you think about it. So I think that we have a lot of tools at our disposal, and we need to be positive and create hope going forward because it exists, not because we want it to be. These are doable things. And I think the issue will be is do we have the will to do them?
Great. And I wonder if you have any recommendations for people interested in learning more about climate change in general, whether it's books or websites, organizations that are doing work on this. Where can people learn more about climate change?
Well, I think for the medical people on the line, there's lots of great organizations that have done great work. So, for example, if you were a physician or a nurse or a healthcare administrator and you wanted to know more about what you can do in healthcare, I don't know of a better agency or better group than Healthcare Without Harm that talks about how to create sustainable healthcare practices. They have tremendous resources for this type of thing. So that's a really great one. And then many of the great environmental groups have worked hard to carve out parts of their identity related to understanding climate. 360.org is a great organization, for example, but there are many, many, many organizations that can help. A lot of this is online. There's an online website called Climate Change, Climate Central. Yale University has a terrific website on climate. Harvard has a terrific website on climate where people can learn more about what's going on and what they can do. So those are just a few examples and resources that people can utilize. And I encourage people to do them. And for a lot of healthcare professionals, there's a lot of courses now you can take. Some of them one-day affairs. I took a 4-month course at Yale a few years back looking at climate and health, which was much more extensive. So there's a lot of educational resources for healthcare professionals as well.
That's great, Paul. And if you can send us those resources, we'll be happy to post it online on our website, acronair.org. And then people can just go to it and access all of those sites. And then I guess soon enough, we'll have the ACR's white paper to add to that list. And I very much look forward to reading that and trying to improve the way that we practice rheumatology and some suggestions about discussing this with our patients going forward. Paul, any last words? Any words of advice before we call it a day?
No, I want to thank you for having me. I think the fact that you have decided to address this issue is a testament to that the ACR views this as a valuable and important topic within the health of our patients. We need to be part of this process of trying to adapt to climate and then mitigate the effects of climate at the same time. Healthcare professionals need to engage in this issue, whether you're a rheumatologist or any other specialty for that matter. So I hope that this will continue to be part of the ACR's educational process moving forward for the years to come.
Thank you so much for your time, Paul.
Thank you for inviting me. Have a great day. Take care.
You too. Hopefully, this discussion didn't depress you or scare you, but instead lit a fire inside of you to help lead solutions in climate change. Well, maybe not a fire exactly, because that produces smoke, but you know what I mean. As Paul said, we need researchers to help study the effects of climate change on people with rheumatic diseases, and also those who lead efforts at reducing waste and our carbon footprint. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this episode, including all the links that Paul mentioned, at acronair.org and on your favorite podcast app. Until next time, ride your bike to work, and of course, stay healthy.